Next, we have a long case presentation on the topic bronchiectasis patient for lobectomy. It is presented by Dr. Hita and Dr. Sachin. The internal examiner will be Dr. Thomas George, Professor and HOD at Pushpagiri Institute of Medical Science, Tiruvalla. And the external examiner will be Dr. Vijish Venugopal, Principal of KMCT Medical College, Secretary of ISA Kerala State.
At the outset, I would like to thank the organizers for this opportunity to be here and to discuss on bronchiectasis. Over to you. Kindly introduce yourself and we'll start the case.
I'm Dr. Hila, PG resident, Pushpagiri Institute of Medical Science, Tiruvalla.
I'm Dr. Sachin George, PG resident, Pushpagiri Institute of Medical Science.
So we'll move on to the case presentation.
So our case is bronchiectasis lung posted for lobectomy. Moving to our case, it's a 52-year-old male patient who is a manual laborer presented with complaints of cough with expectoration for 2 years, shortness of breath for past 1 year, and occasional hemoptysis for past 6 months. And about the history of present illness, the cough with expectoration was present for the past 2 years. It was insidious in onset, gradually progressive in nature, which is more in early morning hours, more on lying in left lateral position. And the sputum was thick white, with half a cup in quantity. It's not foul smelling and occasionally blood tinged. Next complaint was shortness of breath, which was present for last 1 year, which was insidious in onset, gradually progressive, aggravated with exertion and relieved with rest. Initially, he was breathless while walking uphill, now breathless while walking short distance, and there is no history of any orthopnea or paroxysmal nocturnal dyspnea, not associated with any chest pain. The last symptom was hemoptysis. Patient had 2 episodes of hemoptysis for the past 6 months, and the last episode was 3 months back. There is no history of any associated hematuria, bleeding tendencies, or intake of any antiplatelet medications. No history of any significant weight loss, evening rise of temperature, facial puffiness, anorexia, nausea, vomiting, or decreased urine output. But the past medical history, there was history of hospitalization following breathlessness and hemoptysis 3 months back, which was managed in the ward. There is no history of any ICU admission, and there was history of frequent hospital visits with cough and breathlessness in the past, which was managed with parenteral injections and nebulizations. And there is no history of any pulmonary TB, bronchial asthma, COVID, diabetes, hypertension, coronary artery disease, cerebrovascular disease, seizures. No history of any surgeries in the past. About the personal history, the patient is a smoker who smokes 20 BDs per day for the past 15 years. He's occasional alcoholic. He's taking mixed diet with regular bladder and bowel habits, and he's married and has 2 children. For the family history, there's no similar illness runs in the family. Both the occupational history is a manual laborer. There is no history of exposure to allergens, no history of exposure to any occupational hazards. He is not able to go for work for the past 3 months.
Yeah, so from history, you told that sputum production, 3 main features were sputum production, hemoptysis, and shortness of breath. So regarding the cough with expectoration, what would be the normal sputum production per day?
The normal sputum production per day is 10 to 15 ml per 24 hour. And if it is more than 100 ml or 20 teaspoons per day, it is known as bronchoria.
So you have more than 100 ml?
More than 100 ml per day. So here there is bronchoria.
And what about the nature of the sputum? Is it important for?
Yes, we can diagnose different diseases based upon the color of the sputum as well as the smell, that is odor of the sputum. So coming to the quality, that is color of the sputum. In case of bronchiectasis, lung abscess, it will be purulent sputum. Then mucus sputum will be produced in any allergy, chronic asthma. then dusty sputum in case of pneumococcal infections, then pink frothy sputum in case of pulmonary edema, then green colored sputum in case of pseudomonas infection, and
Okay, fine. You said about shortness of breath. How will you distinguish whether this is a cardiac cause of the shortness of breath from history, or the lung is involved?
If the dyspnea is associated with any cardiac illness, there will be associated chest pain and history, whether there is any history of previous cardiac illness, and there will be orthopnea, which is persistent with the cardiac cause of dyspnea.
Which was the first symptom to appear here in respiratory condition?
The respiratory condition, first symptom here, it is the cough with expectoration of sputum. So here, this goes more in favor of a respiratory condition rather than a cardiac cause.
Okay.
What about the hemoptysis? What are the causes of hemoptysis?
Okay, the causes of hemoptysis include, we have cardiovascular causes, respiratory causes. In the cardiovascular causes, we have mitral stenosis, left ventricular failure, and respiratory causes we have lung carcinoma, lung abscess, bronchiectasis, and chronic TB, and bleeding disorders is there, hemophilia or leukemia or disorders.
What is the importance of marital status?
This patient is married and has 2 children, and when he take about the history, if the patient is married, like in congenital conditions like Cartagenous syndrome, the patient may have azoospermia, in which the patient may go for infertility. So this patient is married and has 2 children, so we can rule out Cartagenous from this history.
What about, you said about this his treatment history, right? Is it important for us as anesthesiologists? His past medical history?
Yes, the past medical history, what all other comorbidities the patient has, and whether the patient is having any antiplatelets or anticoagulants, so that whether the hemoptysis is caused to that, or any cardiac illness, and what all are the drugs that to be continued during our intraoperative period, and that we have to be careful. So we need to know the past history, past medical history.
Whether he's stable right now, right? Whether he's getting hospitalized frequently because of this illness. Okay, we move on to examination.
Coming to the general physical examination, our patient was conscious, oriented, cooperative, and was not dyspneic at present. Then accessory muscles of respiration was not in use. The weight of the patient was 66 kg. The height was 172 centimeter. The BMI was 22.75 kilogram per meter square. And on examination, the pallor was present, and the patient had grade 3 clubbing. There was no icterus, no cyanosis, no generalized lymphadenopathy, no pedal edema, and the patient was afebrile. Coming to the vital signs, the pulse rate of the patient was 88 beats per minute. It was of regular rhythm, normal volume, and it was felt in all areas equally, and no radiofemoral delay. The BP of the patient was 140/80 millimeters of mercury in right upper limb in sitting position, and the respiratory rate was 20 per minute, and it was abdominothoracic, and room air saturation was 96%, and the JVP was not elevated or not visible. Coming to the airway examination, the mouth opening of the patient was adequate. The Mallampati classification, the class 2, and the thyromendal distance was 7 centimeter, and the temporomandibular joint was normal. The neck movements was within normal limit, and the patient had no loose tooth or any dentures. Coming to the examination of the respiratory system, first the examination of the upper respiratory system. The nose was normal, and there was no deviated nasal septum, and there was no nasal polyp or sinus tenderness. And the patient had poor oral hygiene, and the teeth was tobacco stained, and the dental caries was present. There was no post-nasal drip or pharyngeal congestion. Coming to the inspection, the trachea was central, the shape of the chest was barrel-shaped chest, no drooping of shoulders, there was no visible pulsations, dilated veins, sinuses or scars. The accessory muscles of respiration was not in use. Then coming to the palpation, there was no local rise of temperature or tenderness. The trachea on palpation was central, and the apex beat was felt at the left intercostal space, 1 centimeter medial to the mid-clavicular line. The chest movements was found to be reduced on the right side, and the vocal fremitus was normal on all lung areas. And on percussion, we found a dull note on right infraaxillary and interscapular area, and normal resonant note all on other areas. And coming to the auscultation, normal vesicular breath sounds heard on all lung areas, and a coarse mid-inspiratory crepitations was found over the right infraaxillary and right interscapular areas, and there was no pleural rub, and the vocal resonance was normal on all areas. Then coming to the bedside pulmonary test, we have performed a bedside pulmonary test in our patient, and the Sabrasi's breath holding test was found to be 20 seconds. Single breath count was, the patient was able to count up to 25, and the forced expiratory time was 8 seconds, and the room air saturation was 96%. Coming to
all of the systems were normal?
yes, other systems were within normal limit.
So you said in your inspection that there is clubbing.
A general examination,
Yeah,
the
clubbing.
patient had clubbing, grade 3.
What are the causes of clubbing here?
The causes of clubbing can be divided into congenital and acquired. And the acquired causes, the lung conditions like bronchiectasis, lung abscess, tuberculosis can lead to clubbing. Then cardiovascular causes like congenital cyanotic heart disease with right to left shunt.
Okay.
Then aneurysms, then celiac disease, inflammatory
So you
bowel
should
disease.
know something about clubbing and or how do you examine all that.
Yes.
And
You said that accessory muscles are active. Which are the accessory muscles?
The accessory muscles of inspiration, it is sternocleidomastoid and the external intercostal muscles, and then the scalene muscles. Then the strap muscles also act as accessory muscles of inspiration.
What about expiratory muscle?
Expiratory muscles is internal intercostal muscles, rectus abdominis, transverse abdominis. These are all.
And what are the positive signs? You had what are the worrying things you get from your examination as an anesthesiologist?
The patient has pallor, so that indicates the patient is having anemia. That might be due to nutritional deficiency or hemoptysis that is leading to anemia. Then the chest signs, where the patient is having coarse crepitations over the right infraaxillary and interscapular areas. Then dull note on percussion.
What about your bedside pulmonary test? Anything you're worried about?
In bedside, first one Sabrasi's breath holding test. It is in the lower limit, that is in less than 20 seconds, and it indicates the cardiopulmonary reserve. In this patient, it is 20 seconds. Normally, it is between about more than 30 seconds. So the patient comes in between the limited cardiopulmonary reserve. And the single breath count is also in the normal level. So it shows a low vital capacity. And the peak expiratory flow time, it's less. It shows an obstructive pattern. No, it's 8 seconds. So it shows obstructive pattern. So this means that the patient has a cardiopulmonary reserve compromise. So we need to optimize the patient before taking him for the surgery.
What other bedside pulmonary tests are there?
Okay, we have, apart from Sabrasi's breath hold and single breath count, we have De Bono's whistle blowing test, right peak flow expiratory rate, then Snyder's match blowing test, pulse oximetry, ABG can also be taken.
And cough test is also present.
What is the role of ABG?
Here, ABG, we can look for the hypoxemia. If we are taking up the patient for the surgery, we can look for the hypoxemia preoperatively. Then previously, ABG was done to look at the lung parenchyma function. If the PaO2 was more than 60% and the PaCO2 was more than 45%, it was a cutoff value for taking up the patient for surgery.
What is that approach is called?
Three-legged stool for the respiratory mechanics.
I will come to it later. You can continue. The positive only if,
Only the respiratory. So coming to the summary, our patient was a 52-year-old, a male who was a chronic smoker with no other comorbidities, presented with complaints of cough with copious amount of sputum for the past 2 years and breathlessness for the past 1 year. The MMRC dyspnea grade of 1 has been worsened to grade 3, and occasional hemoptysis was present for the past 6 months.
So he's a smoker, I forgot to ask. So are you worried about him being a smoker?
Yes, he was an active smoker, so we need to calculate what is his pack here and then to optimize the patient before taking up the for case.
What is this pack here?
The pack index was this patient, he smoked 1 packet of cigarette, that is 20 into for 20 years. So his pack here was 20, which was less than 40. Sorry. He smoked for about 40 years. So it was nearly the pack year was 40, which was significant. If it is nearly 40 or more than 40, he has a post-operative morbidity and mortality is high.
There's more risk of him having even some malignancy also.
What about smoking index? You heard about that?
Smoking index is usually calculated for the patient who was smoking BDs. It's calculated by number of BDs smoked per day into number of years, and which is more than 300 is considered to be very severe smoker, 100 to 300 moderate, and less than 100 mild smoker.
So nowadays they're not smoking BDs and cigarettes. They're having e-cigarettes, vaping.
Yeah, vaping.
It's better.
It has less adverse effect than smoking. The vaping, we are inhaling the liquid which is containing nicotine and other chemicals.
It's containing nicotine, right?
Yes.
The effect of carbon monoxide and others are not there.
So you should not advise them to do that. Okay. So smoking is done. So now, how will you proceed with this case?
We have to.
What is he posted for?
He
Posted for lobectomy.
So
Which
now-
lobe?
Right lower lobes.
Right lower lobe. So how will you go about? Now this patient has come to meet you in the pre-anesthetic room.
So we have to do the basic investigation first, like blood count with blood culture, chest X-ray, which shows ring shadows and hyperinflated lung with linear markings and ring shadows, and HRCT is the investigation of choice, which shows the tram track appearance and signet ring pattern. Along with that, we have the bronchoarterial ratio, which is the ratio with the airway and the adjacent pulmonary artery.
Can you show the X-ray and CT film?
It's the X-ray showing bronchiectasis.
there is.
What is the finding in the X-ray?
Hyperinflated lung with showing linear markings and the opacity in the right lower zones.
And honeycomb appearances also.
Okay. What about the CT? What is the appearance?
Signet ring patterns are in the tram track.
There is also tram track appearance in the CT.
Okay.
Anything else you would like to
We will
do?
do ECG to rule out any RV strain or a right bundle branch block, and we can do 2D echo to rule out RV dysfunction. Along with that, if you are taking the patient for the case, we will do PFD. In this case, it will show reduced FEC and FEV1. And before taking up the patient for the case, we will do the 3-leg stool test for this patient.
You said spirometer, PFT.
PFTs.
What would be the cutoff values in which you would reject this patient?
We are taking normally.
This patient is for lobectomy.
So first we take the FEV1. Normally we say we take FEV1 percentage rather than absolute FEV1, as FEV1 is changeable for age, sex, and ethnicity of the. So we will take the FEV1, and if the preoperative predicted FEV1 is more than 40%, it indicates mild risk. So we can take up the patient. If it is between 30 to 40, we look at other parameters
Post-predictive.
Post-predictive. And if it is less than 30, it's indeed high risk. So we will
Can you
For
tell?
the PGs, can you explain it properly? Because this is a little bit confusing.
Okay.
What do you mean by postoperative FEV1 and postoperative predictive FEV1 percentage? These are the two terms comes. First, you tell about the postoperative FEV1 alone. What is that?
Okay. So predicted postoperative FEV1, we calculate by the equation preoperative FEV1 into 19 minus segments to be removed.
What is the importance of 19?
19 is the total number of segments.
That is bronchopulmonary segments. Okay. Okay.
So 19 minus segments to be removed by 90. So in our case, we are removing the right lower lobe. So the right lower lobe contains 5 lobes. So coming to the equation, preoperative FEV1, in our case it was 2.5. So 2.5 into 19 minus 5 by 90. So we get approximately a value of 1.8. And if the FEV1 value is less than 2, if it is more than 1.5, the patient can be taken for lobectomy. If it's more than 2, patient can be taken for pneumonectomy.
What about the postoperative predictive FEV1 percentage?
Here we are taking the subsegments. So there are total 42 subsegments. In the left side there are 10 and 10 and 6, 4, 12. So and the right lower lobe has 12 subsegments. So coming to the equation, preoperative FEV1 percentage into 1 minus percentage functional tissue removed divided by 100. In our case, the preoperative FEV1 was 55%, and 1 minus percentage functional tissue removed, that indicates total segments, subsegments removed is 12. Total number of subsegments 42. So 12 divided by 42, that comes around 28, 29. So 1 minus 29 by 100, that comes around 0.71. So 55 into 0.71, that's approximately 39. So the patient comes between 30 to 40, the moderate risks.
Okay, good.
Yeah, I think this is how we should go for the risk stratification. Any other risk stratification you would like to do based on your cardiac? No, you do RCRI for cardiac risk index, right? What about in these cases?
Thoracic revised cardiac risk index, which has 4 parameters: whether the patient had history of any coronary artery disease, and it gives a point of 1.5, and whether the patient had history of cerebrovascular accident, which has a point of 1.5, and whether the serum creatinine is more than 2 gram per deciliter, which has a 0.1, and then whether the patient gives history of pneumonectomy in the past, which gives 1.5. So total points can vary from 0 to 5.5. And if this thoracic revised cardiac risk index is more than or equal to 2, we need to optimize the patient before taking up.
So they'll be in A, B, C, D classes. So A and B is okay. C and D, you have to further optimize the cardiac also.
Any other severity scoring systems are there?
We have a bronchiectasis severity index, where we take the
Okay, details you don't have.
then phase indexes, which has FEV1, predicted FEV1, age, colonization by Pseudomonas aeruginosa, and the extension, radiologic extension, and the dyspnea scale.
Okay, how do you now, okay, the 3 legs, you were going with that. So what are those 3 legs?
First one is respiratory mechanics that we said just now. Predicted postoperative FEV1 is the main. Next one is the cardiopulmonary reserve, where we look at the cardiopulmonary exercise testing. Here we look at the VO2 max, that's the maximum amount of oxygen that can be consumed. 3.5 ml per kg per minute. And we have other tests like a stair climbing test, shuttle test, and 6-minute walk test can be done. In the 6-minute walk test, we ask the patient to walk for 6 minutes, and the distance travel, we have to divide it by 30, and it will correspond to the VO2. So the patient is able to walk 600 meters. If we divide it by 30, it corresponds to 20. That means the VO2 max is 20 ml per kg per minute. And if the patient is not able to walk 450 meters, that indicates that the patient is not able to, VO2 max is less than 15 ml per kg per minute. And if the VO2 max is less than 15 ml, it indicates that the patient has poor cardiopulmonary reserve. And the third one is lung parenchymal function, where we'll look the diffusion lung capacity of carbon monoxide. It also taken as percentage. Previously, the ABG was used to see the PaO2 and PaCO2. Now we are doing DLCOs.
In this patient, he's coming under which risk?
Moderate risk.
Moderate. It's 39, no?
38 point.
30. So, what would you do next? Will you accept this patient for lobectomy?
Since the patient is active smoker, we'll advise to optimize and stop smoking and take the case after that.
How will you optimize?
That is a 5-pronged approach for optimizing the patient before surgery. First one, we need to advise bronchodilators for dilating the airway. Then for loosening the secretions, we provide mucolytics, then systemic or topical hydration. Then for the removal of the secretions, for chest physiotherapy, then incentive spirometry. Then we'll educate the patient regarding cessation of smoking for at least 8 weeks, so that the ciliary function and metabolic functions, everything improves. And then educating about the post-operative care, and then the antibiotic, culture-sensitive antibiotic therapy if the patient is having infections.
You said that you will ask the patient to stop smoking. What is the importance of stop smoking? How much day you allow?
We need to ask the patient to cessate the smoking for about 8 weeks. So that if we stop for 12 to 24 hours, the level of carbon monoxide and the nicotine levels will be reduced, and by 48 to 72 hours, the carbon monoxide level will normalize and the ciliary function starts improving. And if we stop for about 1 to 2 weeks, the sputum production will decrease, and after stopping for about 4 to 6 weeks, the PFT also improves, and then 6 to 8 weeks it will
because of the shortage of time.
So you did everything, he's come back for surgery. You have decided to take him up. How will you move on? What is your plan for anesthesia?
You have prepared.
Pre-preparation, everything done. The plan for anesthesia is general anesthesia with thoracic epidural. Then the preferred position is the left lateral position with the posterolateral incision for right lower lobectomy. And after taking up the case to the OT, I'll attach the monitors, then optimize the temperature of the OT. Then first I'll put the thoracic epidural by paramedian approach, and the tip has to be at the level of T4, T5. And after confirming the epidural catheter is in place, then I'll make the patient supine for inducing the anesthesia. I'll pre-medicate the patient, and I will induce the patient with propofol. And here we need absolute isolation of one lung. So the preferred method, there are various methods for lung isolation. Here I'll prefer the double lumen tube for isolating.
Which side?
The left side.
Why?
Because we are operating on the right side, and the margin of safety is more in case of left DLT rather than right DLT.
How would you define margin of safety?
The margin of safety, it is the distance from the carina where we can safely pass the endotracheal tube without obstructing the origin of right upper lobe. So in case of right bronchus, the distance from the carina is 1.5 to 2 centimeter, whereas in case of left bronchus, it is
so
about...
you prefer a left double lumen tube for almost all cases. What are the indications for a right double lumen tube?
Right DLT is usually put in surgeries involving the left main bronchus. In condition like left pneumonectomy, left lung transplantation, left sleeve pneumonectomy, and also in condition where the left side is
okay. How would you size the double lumen tube?
The size can be based upon the gender and the height of the patient. In case of female patients who are less than 160 centimeter, we prefer 35 French double lumen tube. And in females who are greater than 160 centimeter height, we prefer 37 French.
So 35, 37 for female and
39 and 41 for males.
From chest X-ray, can you decide how to put a double lumen tube?
From chest X-ray, we can measure the tracheal diameter, and then
Where?
At the level of clavicle, and that divided at that multiplied by 0.62 will give the left bronchial diameter. Bronch.
Any other method?
From the CT, we can also measure the left.
Any other method?
By USG, we can.
Okay. So you have put in a double lumen tube. How will you know that it is in the right place?
We have two methods, by auscultation and by fiber optic bronchoscope. And auscultation, first we inflate the tracheal cuff, then we auscultate in both areas, so we should hear breath sounds in both sides. Then we have to occlude, inflate the bronchial cuff, and we have to occlude the tracheal lumen, and then we on.
Any other modality which is available in your theater?
USG.
How do you find in USG?
There will be pleural line in the.
Lung sliding here.
Lung sliding.
The lung sliding will be missing. Lung sliding will be present on the other side, and you will get lung pulse on the collapsed lung side. Right? Okay. So you isolated. And do you prefer to use? No, you have already told DLT will be the best. Okay.
Any other method of one lung isolation?
We can use bronchial blockers,
Okay.
UD1 tube, endobronchial tube, and endotracheal tube, which can be introduced into endobronchial.
You said about DLT. Any newer DLT you know?
We have Viva side DLT, where we have a camera placed at the tip so that we can visualize as we pass through the trachea. We also have ECOM DLT, where we have impedance. We'll measure the bioimpedance from the ascending aorta as we can get cardiac output also.
Okay. You have given thoracic epidural. Any other alternatives?
We can give post-operative analgesia.
Yeah.
Post-operative analgesia, I can go with the blocks, these intervertebral, erector spinae blocks, serratus
fine.
anterior.
The surgery is over. Would you like to extubate this patient?
It is based upon the predicted post-operative FEV1 percentage, and if the predicted post-operative FEV1 percentage is more than 40%, we can extubate on table if the patient is alert, awake, and comfortable. And if it is between 30 to 40%, we have to consider the other factors like lung parenchymal function, the effort tolerance, the maximum oxygen VO2 max, and the other coexisting conditions. And if the predicted post-operative FEV1 is less than 30%, we have to opt for steam weaning from the mechanical ventilation.
Thank you. Thank you very much.
Thank you.
Thank you, sir.
And it was well answered and well presented.
Thank you, sir.
All the best for your upcoming exams.
Thank you, sir.
And any comments or?
Thank you, doctors.
Thank you.
Thank you.
Now, I request Dr. Vijish to distribute the participation certificates to Dr. Hita and Dr. Sachin. Now, I request Dr. Shanti to please come onto the stage to felicitate Dr. Thomas George. I also invite Dr. Ram Kumar to please come onto the stage and felicitate Dr. Vijish.
The 49th Annual State Conference of ISA Kerala Chapter will be held on 10th, 11th and 12th October at Ivansa Convention Center, Kozhikode. Please contact the registration counter to avail a special offer today and tomorrow.